Thank you for joining us for this, the 5th webinar of the Royal College of Psychiatrists. Our focus today is on training matters, updates for psychiatric trainees and trainers during the COVID-19 pandemic. We have more than 1,300 people signed up to this afternoon, a record for a college webinar, and a warm welcome to everyone. My name is Ross Runciman. I am the chair of the Psychiatric Trainees Committee, or PTC. The PTC is comprised of enthusiastic trainees from all 4 nations, focused on representing all trainee views to the college and beyond. We are privileged in the PTC in having such a close, collaborative, professional relationship with everyone in the Royal College of Psychiatrists. This means that your views as trainees are heard clearly and acted on. I'm coming to you live today from Cheltenham, where I'm working on a later life patient ward as part of my ST5 year in general adult and old age psychiatry. We chose psychiatry, but we didn't choose COVID. However, I have seen so many fellow trainees and trainers face up to this challenge over the last few weeks in incredible and diverse ways that are both moving and inspirational. We are out of our comfort zones. For me, that means I come to you today in scrubs with a shaven head due to a complex home haircut gone wrong. But more seriously, I'm spending much of my day doing physical medicine rather than psychiatry and finding myself supporting colleagues more than ever, but also needing and seeking much more support myself. I have to be honest, I've been scared, anxious, with moments of being utterly terrified, and I've not always slept well. But in this paradigm shift, there is growth, many leadership opportunities, and so much more learning. So on to today. Thank you to everyone for submitting their questions in advance. It's not too late to have your questions asked and answered, and to submit live questions on the right-hand side of the screen. We'll be taking questions once all the speakers have presented, taking up the majority of this webinar. I would suggest you keep the Q&A tab open, as our kind colleagues Isabel and Katie from the college will be posting links and resources you may want to look through. If you have more general questions, then please direct these to our policy team using the Ask a Question function on the college website. Please also tweet throughout the event using hashtag RCPsych Live. Like I said, we've got a great lineup today, including Drs. Ian Hall, John Russell, Saleema Durgahee and Leanne Tozer. I'll introduce them as we go. Now, a brief note to say that Dr. John Russell will be coming to the end of our presenters for technological reasons. Questions will be then led by our Dean, Dr. Kate Lovett, to bring our panel together and use their expertise to answer your queries. So, can I please introduce our first speaker, Dr. Ian Hall. Dr. Ian Hall is Chief Examiner at the college and works as a consultant psychiatrist for people with intellectual disability in East London. He'll be talking about the MR Psych examination during the pandemic. Over to you, Ian.
Hi, yes, thank you very much for that that introduction, Ross. And yeah, first of all, I'd like to apologise for the cancellations that we've had to do with the exam because of the pandemic. We left it as late as we could, but then we realised it was just inevitable. We had to cancel paper B at the end of March, paper A, the forthcoming sitting in June, and the Singapore CASC. So many apologies for that, because we're fully aware of the incredibly disruptive effect it has on trainees, and you know how galling it is if you prepared for an exam, especially and you can't actually take it, and also all the very legitimate worries about progression and the effect it might have on progression. So from the college, we'd really like to apologise for having had to do that. So I'm going to talk about first the written papers and then the CASC and what we're doing for both of those. So for the written papers, we have the paper B that we set for March, and we have just finished setting the paper A that was initially planned for June. So we have those, if you like, ready to go when we have a way that we can deliver them. We want to deliver them as soon as possible, but there's lots of problems in the way. What we're thinking, I think the most likely thing that is going to happen is that we're going to deliver online exams later in the year. So that's much more robust against any social distancing restrictions or any repeatable lockdown. So we'd already been thinking about this, but obviously we've really accelerated that. We're talking to several different providers who might enable that. We think actually it's going to be doing it at home or at work on your own device rather than going to a test centre to do it, because if you go to test centres you still have the social distancing problems. So if you have it at home, we will be using what they call remote proctoring, or watching you while you're doing the exam. There's two basic ways of doing that. One is that we might go with. There's some ones that we would choose not to. One is having someone watch you do it, and one is basically using artificial intelligence to look for behaviours that might indicate inappropriate activity, such as reading stuff off the wall or having someone under the desk telling you the answers, or that sort of thing. So actually, as we've looked into it, the technology is quite advanced about this, and we are pursuing that. I think the most likely thing is we won't be able to run an extra diet before October or December, but if we can, we will, and we do have those diets ready to go. We're also, in case those, because as you will know, with procuring IT, it can take a long time, and there can be delays in it. So we will also be looking at a social distancing paper-based option as well. So we're trying to cover all bases with that. So that's basically what we're doing about the written papers. With the CASC, that's more difficult. I was saying at the exam committee, if you wanted to design a method to spread COVID around, the CASC exam in a way is a way to do that, because you meet so many different people moving around the stations, and then you have the mark sheets which are transferring everywhere as well. So on the other hand, the CASC is very difficult to organise. I mean, of course, we've all been doing a few telephone consultations, video consultations, and you might conceive that maybe we could run the CASC in a video consultation type way, but the logistics of it are incredibly complex. So I think the most likely thing is the CASC is that we'll explore a social distancing option for the dates in Sheffield. That would reduce our capacity on those days, the 4 days that we have in Sheffield. So we'd like to be able to for everyone to take the exam who wants to. So we're looking at extending the days. We are also exploring online options, but there's no one has done online OSCEs like that before. So I think that's a less likely thing that will happen. But we're exploring both options, but we're certainly hoping to deliver a CASC in September. So that's the main thinking where we are now. So there's no definite answers yet. We're hoping to stick with the existing dates in the exams calendar for this year, but through those different ways. Someone asked a couple of questions about training. And what training you can do. I would definitely, if you're thinking of doing the CASC, I would definitely try and do as many consultations as you can in whatever format. That will be good training. And in terms of practice, I would, obviously you can use the Zoom and so on to try and do that as well. And then that's I think that's basically all I wanted to say. I'm sure there'll be a few questions about how the exams might operate and the detail of that, but we can address that in the Q&A later, but I don't want to go into everyone else's time, so I think I'll leave it there. Thanks, Ross.
Thank you very much, Dr. Hall. Can I move us on to our next speaker, Dr. Saleema Durgahee? Saleema is a new consultant liaison psychiatrist at mental health liaison team at the Royal Sussex County Hospital in Brighton, and currently interim leadership tutor for Sussex Partnership NHS Foundation Trust. Saleema also co-facilitates the RCPsych Leadership and Management Fellowship Scheme with Dr. Michael Hobkirk, and is programme lead for the HEE KSS Embedded Clinical Leadership in Practice Scheme for higher training and SAS psychiatrists. Over to you, Saleema.
You're just on mute, Saleema, sorry.
Thanks for the prompt. Thank you, Ross. I wanted to start with a shared reflection. I think that you drew on there, Ross, in your introduction, sort of a collective acknowledgement that it has been a really hard time for trainees and for all doctors really working in the NHS at the moment. Being a doctor and a psychiatrist means that we may have been affected in many different ways. So personally, in terms of our emotional reaction to the situation, or the concern we have of our own physical health or those of our families. Professionally, having to use clinical skills we haven't used for a long time, or as well as supporting our general nursing colleagues, who many of whom don't have general adult nurse training, adapting to working from home, and of course the impact on our own career progression and development needs. And of course we're members of our own communities where we live, where our friends and neighbours may have looked to us for advice and support. So it's certainly been a really overwhelming time. But on reflection, I also think this has been a time of a huge opportunity, really, for us all to learn more about ourselves, the colleagues we work with in our teams, to build relationships within the wider trust we work in, and with our acute service colleagues, actually. And also to ask the people who use our services of their experience, to draw on their insights, to highlight gaps and improve services further. And whether we know it or not, it is actually more than likely that each of us has engaged in an active leadership in any of those areas over the last few weeks. It's often thought that to be a leader, you have to be involved in a high-level trust project, be in a senior role, or have many years of experience, but that's a bit of a myth. And leadership and the learning gained is so much more than the physical project or the piece of work that we might be doing. Listening to our colleagues over the last 5 weeks, I've been really struck by 3 acts of leadership. Firstly, on the ground, the feeling is of uncharted territory, uncertainty, fear and anxiety. But as psychiatrists, from a day-to-day clinical perspective, we offer our patients a means of understanding their experience, and those skills are so transferable in helping us to make sense of the situation. In addition to that, due to the social restrictions placed upon us, we've all had to make adjustments, prioritising time out and activities with family, exercise, resurrecting hobbies, and maybe connecting with friends and family that some of whom we haven't spoken to for many years. But I wonder if we can use this period to better understand our response to stress, to uncertainty, to think of ways to manage this in ourselves, and perhaps how our insights can help support our colleagues, both within the medical sphere, but also the many colleagues that we work with in our MDTs. Of the latter, I know of junior doctors on an inpatient mental health unit, which includes a COVID-19 isolation ward, where they've noticed this, and they've set up a weekly meeting to do something different together to boost and sustain their well-being. And activities so far have included mindfulness practice, yoga, and a quiz last week. Other junior doctors have collated lots of well-being support information, because there is lots out there at the moment and it can be confusing, and produced posters for communal areas, and in some cases it's been extended to the acute trust. Secondly, we've had to endure disruption to our career progression, with a real felt loss around the lack of regular education and training sessions. But that's really led to a renewed sense of importance, and there's been a real opportunity for novel learning and mentoring experience. Some junior doctors have come together to create their own mini learning programme, an hour or 90 minutes a week, to present topics with support from clinical tutors during their redeployment. And some junior doctors on call have been making themselves accessible to consultants who might be acting down, to provide clinical support and advice, akin to a reverse mentoring role. As COVID-19 is a physical threat, you may have experienced that your non-medical colleagues might be looking to you for advice and support and reassurance at this time. And Ross and I were actually discussing this very point the other day, and how we may not feel completely confident in our physical health skills. But actually, this is a really lovely opportunity to be open and transparent with our colleagues, and to model that at this time we may not have all the answers, but by working together we can really arrive at solutions. It's an opportunity to use your skills, your clinical skills, take a lead in the MDT, and provide truly holistic care to your patients. I mean, these are just a few examples of what I've heard on the ground and heard from junior doctors across the country, and I'm sure that there are many more. And as you start to think about the things you might have done or have been part of over the last number of weeks, it might be helpful to have a structure in your mind. And the Faculty of Medical Leadership and Management Standards of Medical Professionals usefully sets out the how and the what medical leaders do over 4 domains. And we'll be sharing those at the end of the session today. My final thoughts turn to those of us who feel that they might lack confidence or do not see themselves as a leader. I've got to say, I felt like this too. I only finished my training in November, and I totally feel that too. And it does take courage to step forward. And so I leave this final thought for doctors in positions of leadership already, from trainee and SAS reps, supervisors and trainers, and senior clinical leaders, and even executive board members. How can we recognise, how can we empower and support all doctors to engage in acts of leadership and provide meaningful space to reflect on this at this time? Thank you. Over to you, Ross.
Thank you, Dr. Durgahee. Can I move us on to our next speaker, Dr. Leanne Tozer. Dr. Leanne Tozer, ST5 from Live Well Southwest, based in Plymouth, will be sharing her experiences of shielding during coronavirus. She will be talking about the impact of shielding and the ways she has found to stay useful and connected through this period, whilst also continuing her training in psychiatry. Over to you, Leanne.
Thanks, Ross. So yeah, this is my story. Once upon a time, back in early 2020, I was a normal ST5 working in liaison. Well, as normal as anyone working in psychiatry can be. Except I wasn't. I was immunosuppressed due to treatment for an autoimmune condition. Ill health was no stranger to me, and neither was taking a risk to do the job I love. At the end of the day, anyone working in a general hospital with immunosuppression takes a risk each and every day, even before we ever heard of the dreaded COVID-19. Then a letter landed on my doorstep that triggered a series of events and emotions I can honestly say I've never felt before. Like anyone who received that shielding letter, I am no stranger to sickness and a fluctuant ability to work as I would once have considered normal. Despite this, my immediate reaction was one of feeling useless, isolated, and of standing apart from the NHS front line. I felt guilty about my colleagues putting themselves at risk while I was being protected at home. And in a way, this made me feel even more vulnerable to the virus itself. So for self-preservation, I decided to put myself out there and do what I could from home to lift a little of the burden the impending crisis was putting on my colleagues. As I'm sure you can imagine, I was rapidly inundated with requests, ranging from writing a few discharge letters, putting together a presentation for the brave new world, or at least a brave new world for me, of the virtual education of medical students. Once my colleagues realised that I was willing and able, an irreversible tidal wave ensued, to the point I was left wondering whether I ever found time to see patients or being confined to barracks at home. Everybody's favourite phrases became, "Could you just?" or "Would you be able to put something together on?" It was fantastic. Within a few days, I'd regained my sense of usefulness and my purpose. There was no time to dwell on being stuck at home, and that sense of being remote from the front line evaporated. I have fantastic colleagues who keep me included, and I'm never short of something to do, that's for sure. The other thing about fantastic colleagues is you can open up to them and lay your insecurities on the line. We're carers by profession, but it seems, at least for me, to go hand in hand with a difficulty in asking for help. My main worry at the outset was sourcing the basics. I was no stockpiler, and I found myself living off tins in the freezer within a week or so of not leaving the house. Little did I know that my new team's consultant had a wealth of local knowledge about farmers who were delivering in the area, and I can honestly tell you I've never been so overjoyed by the sight of fresh pineapples, leeks and carrots on my doorstep. It just showed me that plucking up the courage to vocalise your worries can lead to solutions without charity or any of those other things that we worry about when acknowledging we need help. I would implore anyone shielding to think outside the box about what you can do to benefit yourself, your colleagues, your organisation. As has already been said, any crisis forces us to think and do things differently, and COVID-19 is no different. But that also means there's loads of opportunities to improve services, even if you're stuck at home. I may now sit working on a gym ball at my desk. It allows me the movement that my body needs. But in my now 46 days of isolation, I have redesigned the psychiatry curriculum and I'm now delivering it to our medical students. I'm supervising our junior doctors across the country. I'm organising and facilitating balance and CPD groups. I'm heavily involved in our restructuring of community services, and I'm working behind the scenes triaging patients that need to be prioritised or whose usual support could be adapted to an alternative or a safer way of delivery. I've collated information about resources available during COVID, and I'm now working with the CCG to make this available to everybody. I have colleagues who are much more fun than me, and they're putting together weekly quizzes, craft competitions, virtual book clubs to ensure that colleagues remain connected and talking to each other on a regular basis. I now walk on a treadmill in my commuting time. This helps me separate my work and home life. It sounds really daft, but psychologically it helps separate that personal and professional within the same house. Trainees are ideally placed to make real change during crisis situations when traditional barriers are broken down. We've rotated for a long time, and so we've got professional networks that extend beyond that of pretty much any other staff group. We're perfectly placed to provide overarching opinions on service development, and we're able to uniquely liaise and collate information to prevent that silo repetition of working. And while protecting your own sanity, you can still progress towards your RCPs, management leadership, QI, psychology, and even the clinical work. As technology and my IT skills have caught up, I'm now slotting in clinics to squeeze in some virtual face-to-face time with patients. Disability had never crossed my mind when I chose psychiatry. It was something that happened to other people and definitely never to doctors. However, with hindsight, it's a wonderful thing, and I regularly thank my younger self for choosing psychiatry, choosing a specialty that's so perfect for me, and not because of my disability. Psych allows me to work with my disability, to utilise the strengths it's given me and adapt away those downsides rather than fight against it and work in spite of being disabled. And I have to say, this has never been more true than in the current situation. So thank you for listening to my story.
Thank you so much, Dr. Tozer. Can I now move us on to our final speaker, Dr. John Russell. Dr. John Russell is the Associate Dean for the Curricula and Chair of the Curricula and Assessment Committee. He will be talking about how to prepare for the ARCP in light of COVID-19. Over to you, John.
Great, many thanks, Ross, for the introduction, and apologies for the technical issues in joining up. Anyway, it's sorted, so our blood pressures can go down. So thank you very much for inviting me to speak. The first slide, I think, is on the screen already. So obviously, this is just how to prepare for ARCPs in light of COVID-19. So there's the background to this. There's been quite a lot of work being done over the past week or so by those on the screen to formulate the college's ARCP decision aid for this year, and so especially acknowledgements to all those who've helped out with that, and also obviously, and Chris O'Loughlin had spent a lot of last weekend trying to pull things together, so it's all much appreciated. So just moving on to the second slide, Isabel, please. So I've just split this into 4 sections for the ARCP, and one is obviously, the first one is workplace-based assessments. Now, obviously, we appreciate that a lot of people things have changed. A lot of people's time is being utilised very differently, and so we're waiting for GMC approval for there to be a potential reduction in the number of workplace-based assessments just for this year, that a reduction in minimum numbers just for this year, to see if that would be of help. Also potentially some flexibility within the workplace-based assessment requirements, because obviously in core and certainly other some of the higher specialties there are different requirements in each of the years, and also the potential to use donks in core training where appropriate. The form has been adapted previously by the Curriculum Committee to ensure that donks can be used for core trainees, but they haven't actually counted. So these are some of the things that we have the potential to adjust, but we are pending GMC approval for that. Obviously, for trainees and trainers watching, or both watching, there's no change to the minimum requirement for reports. So obviously 2 psychiatric supervisor reports and 1 educational supervisor report per year to help feed the ARCP decision making. Obviously the psychiatric supervisor reports, there is still a requirement for trainees to fill in the form prior to their meeting with their psychiatric supervisor as currently, which I know it is a long form and it covers 19 ILOs, but we're keen for that to occur occur this year. But on each of the forms, both the psychiatric supervisor report and the educational supervisor report in the portfolio, we have adjusted. We've added a couple of extra sessions to reflect on the changes that may have occurred to your training. So two questions. Do you wish to comment on the effect COVID-19 may have had on trainee performance and or ability to meet competencies? And also for the trainer, do you wish to comment on the effect that COVID-19 may have had on your ability to assess the trainee? So obviously we felt that these were important to additions to have for that. And thanks to Liz for her help with the wording of that. Next is outcomes. Now things have been circulated regarding outcomes, but it is expected that most trainees will still receive the same standard outcomes that they do currently. The Gold Guide 8, the 8th version of it, which is out at the moment, has been adjusted, and there are 2 new outcomes, which are an outcome 10.1 and 10.2, plus new C code, and there's also a new N code. Now those are more for the panels, and rather than going into every single permutation, I think there is COPMed guidance, Conference of Postgraduate Medical Deans guidance, that is for all colleges. This is not just for psychiatry. These outcomes are for all colleges, and so those are available and for guidance, and ARCP panels and trainers, and especially educational supervisors and TPDs will be able to access those to help guide the panel, because obviously nothing should be a surprise when you get to ARCP. The next part is on reflective practice. So we've not made any changes to the previous recommendations of reflective practice. That's been circulated previously. We're in a slightly unusual situation, but in England, HEE are proposing a self-declaration form in addition to the standard form R, which we only learnt about in the last day or so. And there's something on that about, you know, how trainees have been able to have managed the COVID situation. So, but we're not quite sure what that says yet. But what we have developed is an optional college COVID-19 reflective report, which is going to be available on the portfolio, and which is in part Appendix B of the college ARCP guidance, and also I'll show you that in a second. So those are the main 4 areas that I thought we should focus on for this. So Isabel, the next slide, just to show the first page of the reflective report. So we've developed this report. Now you'll notice that what we've tried to do is to and this is really to help with PDP, the personal development plans, which are obviously in the psychiatric supervisor reports and the educational supervisor reports, given normally, as well as obviously with the pandemic. So on the left hand side, we've grouped a lot of the ILOs into a slightly different framework, and along the top we're asking, how has working with the pandemic enhanced your competencies? What competencies do you feel you've struggled to develop? as a result of the pandemic, and also what areas do you wish to highlight for development in the psychiatric supervisor report. So that's one page, and just to go down to the next slide, Isabella, if that's okay. So it's just two or three more things. So it's really, it's mapping to the current curriculum. The ILOs are all covered. It's just we thought we'd group things in a slightly different way, rather than the 19 ILOs, just to group things in a different way, still show it maps, and it is not compulsory, but it's an optional form which we wondered might be helpful for you to help inform the PSR, the discussions and filling in the psychiatric supervisor report and then the educational supervisor report. So that's there for usage, as I say, and we're hoping it should be of some help. Also, just finally, I've been through one of these with my current CT3, and so what we were also thinking was we would upload a sort of sample reflective note, which would help guide trainees, and obviously yourselves as trainees, what might be of, just to guide some of the how to fill it in, or just some ideas about areas, because I think my trainee will be having similar experience to a lot of trainees around the UK at the moment. So that's what we thought we'd do. So thank you. That's the end of my.
Thank you so much, Dr. Russell. I'm very grateful. And now Dr. Kate Lovett, Dean of the Royal College of Psychiatrists, will lead us in answering your questions, which I can see have come in before and on the right hand side of the screen. Dr. Lovett?
You're just on mute, Kate.
Good afternoon and welcome to everyone, and apologies that I was muted for a minute there. It doesn't happen very often, as my family keep on telling me. Anyway, I just want to say huge thank you to our presenters this afternoon. I think that was a very rich programme, and I've learned a lot from listening particularly to Leanne and Saleema, so thank you. And thank you to everybody who submitted questions in advance. They're fantastic. We've got over 50 that have come in advance, and we have a number that have been coming in during the live session. So I'm going to start off with the first question, which I'm going to ask Ian Hall to answer. Ian, can you propose areas of good practice or suggest ideas about how trainees can prepare themselves adequately in the absence, quite often, of regular patient interactions and opportunities for the CASC exam? And similarly, can we advise organisations, medical education departments, for example, who would ordinarily be holding CASC revision practices, about how they may be able to support trainees with the CASC preparation? So that one to Ian.
Yeah, thank you. Thank you, Kate. Someone needs to mute, so myself echo back. In terms of opportunities to practice, I think you need to seize any clinical opportunity. I do think with these different forms of consultation we're using, actually there's more opportunity for sort of direct observation practice, and certainly I've been doing that with my trainees. So actually I've been finding it easier to do workplace-based assessments, and then of course that's useful for the CASC as well, and how actually did you run this consultation, and to reflect on it. Yeah, we've had some questions saying that education departments have packed up slightly. I think hopefully, certainly where I am, they've got going again, and I delivered a session on our MRC Psych course last week using, either Zoom or Microsoft Teams, I can't remember which one. You know, that was quite well. So I think we certainly should be advocating for this and asking why they're not doing it. And I think you can run CASC revision sessions along those lines as well. We're starting to explore, I run a simulation program for our foundation doctors, and we're starting to explore how we can do that using these new platforms. But yeah, so you obviously need to adapt the way that we learn things, but definitely we need to be doing that. Was there anything more to the question, Kate? Sorry, I didn't write it down. That's my answer concluded. Well, while we're waiting, I'll talk about the exam regulation. So I forgot to mention in my talk that we did in consult after speaking to the GMC, we asked if we could loosen our regulations for taking the CASC. So because we've had to cancel a paper A and a paper B, you can actually take the CASC without passes in the written papers. And this is going to be in place for a year until June 2021. So it would affect the September CASC and the January CASC, and also the Singapore CASC for people who are doing that.
Thanks very much, Ian. I wonder, while we're just waiting for Kate, whether we could trouble John Russell for an answer to a question that I saw that came up last night as a pre-question. So one of those was around the mix of workplace-based assessments. Now, I know you discussed this a little, John, in your segment, but it was just to clarify that a number of trainees have said, well, hang on a minute, there's a reduced number of workplace-based assessments. What does that look like? I think, oh, you're on mute, John.
Mute, that's fine. Yeah, so thank you, Ross. I think it's obviously we've made some suggestions, or we have some suggestions about how we could reduce, or how trainees could be more creative, potentially with workplace-based. So, for instance, if there's a requirement for a journal club presentation, or you know, then actually could they use a case-based discussion to bring in some discussions about research or audit, or do it that way rather than presenting a case or a journal club. So there is that we were talking about that, and also whether donks could be used in core to demonstrate some of the skills, because obviously donks is technically it's a direct observation of non-clinical skills, but obviously if you are participating in a Teams meeting, or you're perhaps chairing a Teams meeting, if you're at the end of CT3 for instance, could that be used to highlight some clinical skills that you've been gaining, or leadership skills or flexibility, etc. So I think that's more, but the problem at the moment is we're waiting for GMC approval, so obviously it is a little bit tricky. We're hoping to get that really quickly. One of the other questions I've noticed, Ross, is obviously we're waiting for GMC approval, but obviously some panels will be sitting in 2 or 3 weeks time for ARCPs. So obviously trainees will not, in that case, there's not much time for trainees to follow the new guidance, but they may already have done more, the required minimum number of workplace-based assessments as per the current guidelines. And as Ian says, and I've found actually I've actually done more workplace-based assessments over recent weeks on call for trainees as well, because actually it's a great opportunity to do a case-based discussion. So I suppose it's about being more creative about getting workplace-based assessments. But I do appreciate that time is passing, and as I say, we only had this information from the GMC this week about seeking approval. So I guess it's about being as pragmatic as you can, but I do appreciate time is passing, and some trainees will be almost at ARCP. So
thank you.
Time is passing.
Kate?
Kate Love is now joining.
Thank you, Kate.
Fantastic. Thanks, Ross, and thanks everyone for holding the fort. There's nothing that this COVID-19 pandemic hasn't taught us all about flexibility, and here we are back on the telephone. So next question I'm going to direct please to John Russell, and this is a really important question. You know, we assume that our trainees have been with us for quite a bit of time, that they, you know, they know the ropes and all the rest of it. But this is one from a CT1 trainee who started in February, and says, as I only started in February, I didn't really get to grips with the e-portfolio before COVID struck, and that's absolutely right. It was only a few weeks before we went into lockdown. I'm now doing outpatient teleclinics from home, as I've been told to self-isolate for 12 weeks, and I suspect everyone's working lives, supervision and so on has been disrupted. Can you give me some guidance, please, for us e-portfolio novices about exactly what we'll need to add to our e-portfolio to satisfy the ARCP panel? For example, how can you do an ACE while working from home, etc.? How will COVID affect portfolio requirements, and will this be standardised nationally? So that one for John.
Yeah. Yes, thank you, Kate. I mean, I think it is, you know, doing an ACE working from home could be difficult. I guess it could be possible if you're using near me technology. I don't know if everyone's using that, but when, you know, you can potentially incorporate, from my understanding, you know, if you're interviewing a patient, you can have somebody else on the screen with you, potentially a supervisor or a senior nurse, for instance, who potentially could, or certainly a clinical supervisor could do an ACE. But I think it is about organisation and trying to I say be more creative. I do appreciate it's very, very difficult, but certainly it might be possible to use near me technology to help do an ACE or even a mini ACE if you can get somebody to effectively sit in with you on the consultation. I think the other part of the question from my recollection is about, I was trying to touch on it previously, we are, you know, we do feel slightly in a strange position, because we have got recommendations on reductions and adjustments to the workplace-based assessment, but we're just waiting for the official sign-off from the GMC. And I was saying earlier, Kate, that actually time is passing, and so trainees do need to know. So as soon as we get that, we will let trainees know.
Brilliant. Thanks, John. And you know, we've been very keen and to get guidance out as quickly as we could. I will be very surprised if our guidance isn't accepted, to be honest. So I would advise trainees and trainers to go and have a good look at the guidance, which is on the website that we've produced. As I say, I think it'd be surprising if it's not accepted. It's completely in line with the ethos that all the educational bodies involved in this, so the education bodies such as HE and NHS Scotland and the GMC, I think, really get the impact that COVID is having on trainees and trainers and services. They don't want to hold people back. They want to support people to progress in their training, you know, and do absolutely everything within all of our power to make sure that happens in a safe and kind of measured way. So have a look at the guidance, and my letter at the beginning of that, I think, really summarises the messages that we want to get to everybody. Please don't be worrying about this. Panels get it. I think one of the questions has said, you know, people making these decisions don't understand the front line. Many of us do. You know, I'm sat in my office in Plymouth at the moment where I run clinics. I do residential on call. I've got lots of contact with trainees and very aware of the pressures that everybody's under at the moment. And I know that, you know, throughout colleges and bodies, there's very strong representation. We also work very, very closely with trainees. And as you know, Ross is there on a, you know, COVID old age ward. You know, we have contact, we get it, we have contact with people who get it, and we'll do everything we can to support you. I'm going to move the questions on now to Leanne, if that's all right, because there's a good question here that, Leanne, I think you might be in a position to answer. And this is, it says, there are sometimes misunderstandings about what shielding means. which may result in trainees who are shielding feeling unduly pressured to leave home, for example, just to attend a meeting, when it's been strictly advised against in the NHS shielding letter. This might be even more of an issue when distancing measures for trainees are relaxed, but vulnerable trainees still have to shield. So that question is to Leanne, and there's an additional bit about, will the college be releasing specific guidance for training programs and trusts on how shielded trainees should be supported to work from home? Well, I'll answer that bit first before we go to Leanne, but we haven't done so far. There is some guidance in the ARCP document which specifically mentions shielding, but it sounds like it might be useful for us to develop some more specific guidance as time goes on. I have to say, it worries me if people are feeling pressured to do stuff that's putting their health at risk, but I'm going to pass that on to Leanne. What would your advice be, Leanne?
Thank you. Yeah, I think it's a very difficult issue, and I think it can be really frustrating. And I've had it a few times now where people have been, oh, but aren't your 14 days up yet? Very much assuming that this is a self-isolation rather than full shielding. And actually, I've just used it as an educational opportunity for them to explain the difference between full shielding for those people who are immunocompromised on cancer treatments and fulfill those criteria that were in the shielding letter, as opposed to those who are vulnerable or have other things that make COVID a bit more serious for them.
Great. So thanks, Leanne. I think that's really clear. I mean, you need to have sort of, quite assertive skills to do that, don't you? And I'm just wondering if I could bring Saleema in now. It's easy to have that conversation with people where you maybe don't feel a power imbalance or a sort of sense of threat. From a leadership perspective, Saleema, what advice would you give to trainees who find themselves having to have what might be quite a scary and difficult conversation about shielding?
Thank you, Kate. Well, I was thinking a lot actually during that sort of question and how it was delivered and explained there, and I think in very difficult sort of circumstances, I often think around Michael West's work that he's done on compassionate leadership and compassionate understanding, and his sort of 4 phases, if you like, in terms of approaching any kind of dilemma or situation, and there is this sense of being able to sort of use active listening to sort of listen with fascination, so you can develop a shared understanding in terms of what is going on between you. What are the differences here? What are the positive and negatives? And then together work through what might be towards a solution, or even finding out together what might be the right recourse here. And being able to sort of bridge that misunderstanding, I suppose, means that you're able to kind of manage that power differential that might be there in the background. And I having been a registrar very recently, very aware of how that really puts you on the back foot, or how that feels to sort of experience. But it's actually worked in that respect, in terms of using this sort of a method of being able to develop a shared understanding to level that power differential, and to have a sense of where both of you are coming from, and then how to work together to sort of come to a solution or arrive at a mutual understanding.
Brilliant, thank you. Our next question, and I think this is one that we could maybe put to a couple of panel members. So I'm going to ask if Leanne could have a stab at it, and Ian have a stab at it as well. So this is from a trainee who's due to start training in core psychiatry in August. So first of all, just like to say congratulations. That's a brilliant choice, and we're really looking forward to having you join us. But the specific question is, in light of the current pandemic, can I expect my training to commence as planned? And what types of disruption am I likely to experience? So absolutely, there is a complete commitment for rotations to change as planned in August, and that comes from the highest level. So the education bodies, HEE, NHS Scotland and so on, are all signed up to trainees rotating as normal in August. There is no plan that will be disrupted. But what can people expect come August in terms of training? Ian, do you want to have a go at that one?
Yeah, of course. Yes. Yeah, so I think, well, of course, the whole world has changed. I think we're all gradually realizing this. So I think the way that we practice is going to be different for a long time, and aspects will be different forever. And I think we will do more of what they used to call telepsychiatry or remote psychiatry. That is going to be more in place. But I think as John was saying, I think that doesn't, and hopefully I was saying earlier, I think that doesn't mean that we're not going to, it's not going to be good training experience and we're not going to learn clinical skills. And actually, personally, I found it very rewarding to practice clinically in a bit of a different way, and to think how we're going to apply that. In terms of the actual exam, yeah, as I was saying, really, we certainly want to continue to offer the exam, but again, I think we're going to make a permanent move to online delivery of our theory papers, and yeah, we're still working on what we're going to do about the CAS. But I think that, yes, that element of training and going through these thresholds will still be there. Yeah, I think that's what I want to say.
Fantastic, thank you. And Leanne, I mean, you're out of all of us closest to remembering starting core training, and you're also very close to delivering remote training at the moment. What changes can you foresee, and how can you envisage how we're going to support our new colleagues who are coming to join us in August?
Thanks, Kate. I think things are definitely uncertain for the future coming towards us, and I think that's going to be the same across all specialties, including psychiatry. There seems to have been a lot of changes that were coming anyway that have been expedited because of the crisis. So things are definitely going to be different, but not necessarily worse. I think there's a lot of creative solutions that we can come, and I think there are lots of uses for technology that will probably mean that things are done in a similar way, but not necessarily delivered face to face. So we can really utilise technology to make sure that those opportunities are still there.
Fantastic. And I think, I keep thinking we've implemented such a lot of positive change in all of this. We've had discussions in the past about should we be forcing trainees to travel long distances for RCPsych courses, and wouldn't it be better if we did it online, and so on. And I suspect that those conversations are going to be a lot easier in the future when we're thinking about people's mileage and time and so on. We're probably going to be in a position to be a lot more confident about developing sustainable alternatives. So John, there's a question here again about ARCPs and workplace-based assessments, and our recommendation of reducing to 12, which we think is likely to be accepted. How are those going to be distributed between the various types of assessment? I think you've covered this or touched upon it already, but just to be really clear to people, can you tell us about the flexibility that is expected?
Yeah, thank you, Kate. I think there's a proposal to reduce all workplace-based assessments by a third. So it depends on where you are in core and where you are in higher as regards the reductions. So I'm guessing, obviously, if we're thinking about ARCPs, the panels will need to know mainly if somebody's clinically got the competencies to be able to progress. So I was saying earlier, some of the other workplace-based assessments will be like a case presentation or a journal club presentation or something, will perhaps be take less priority than maybe the ACEs, if you can do them, as we've said, mini ACEs. Case-based discussions, I think, will be very useful. We've talked about donks as well, and obviously there's mini PATs going on. So we haven't actually specified where the reductions are. I think it's more about having discussions with the supervisors, saying it's and concentrating on the clinical ones, because obviously these are probably, patient safety needs to be maintained for, and progression, etc. So those are probably the ones I would advise that should be done where possible, using new technologies, etc. So I think that's where I would be what I'd be advising on. I think I can't remember, there was another part to that question. It's gone out of my mind.
No, I think that's covered it, John. It is about the mix of them, and basically there is flexibility, and please discuss with your supervisor. It needs to be tailored to your individual circumstances and what you can achieve at the moment. I'm aware of time. We've got some absolutely brilliant all the questions are really important, but some really pertinent questions. We're not going to be able to answer them all in this webinar this afternoon, but I want us to answer them to give you clear answers to the important questions. There's some good questions about PPE, what the college are doing. We're doing a lot on that, and we will post some answers on that later. There's some good questions about recruitment that has been out with our control, unfortunately, and I know that some people outside of training, are very disappointed that because of the rules introduced, they've not been offered a place. We'll give some formal written response to that later as well. There's also some really good questions about the length of the pandemic, and although we've all been focused in this phase on priorities at the moment, it's clear that this is going to go on for some time, so we'll get back on those. And some questions about the exam in the future, about progression to higher specialist training without the exam. We've resisted that. We think that the exam is very important, and we've done everything and will continue to do everything to support trainees be successful at the exam within their training period. But like everything in this situation, nothing is off the table, and we will continue to review constantly as we go through this. So I'm just going to say thank you to everybody and hand back to Ross to end the webinar. Ross.
Thank you, Kate, very much indeed. Thank you so much to all our speakers today, Drs. Ian Hall, Saleema Durgahee, Leanne Tozer, John Russell and Kate Lovett. I'd also like to thank the work done by everyone in the college, which has enabled today's event. People have been expertly working in the background, including Isabel Brinsden, Katie Newton and Catherine Squire. We'll be collating, as Kate said, all the questions asked today and circulating to the speakers for responses and uploading these to the website alongside the webinar recording, so you can look back and see what's been discussed and make sure your question's been answered. You can continue to send in training related queries and questions via specialitytraining@rcpsych.ac.uk, but please don't forget your local PTC rep you can find via the college website. Trainees and trainers have all risen to this COVID driven situation. We're all doing an incredible job of it, I think, and I feel very lucky to be part of this big psychiatry family. So to finish, if you'll indulge me, I'd like to quote a little of Marianne Williamson's poem entitled Our Deepest Fear. Our deepest fear is that we are not inadequate. Our deepest fear is that we are powerful beyond measure. It is our light, not our darkness, that most frightens us. We ask ourselves, who am I to be brilliant, gorgeous, talented, fabulous? Actually, who are you not to be? Your playing small does not serve the world. There's nothing enlightened about shrinking, so that other people won't feel insecure around you. And as we let our own light shine, we unconsciously give other people permission to do the same. As we're liberated from our own fear, our presence automatically liberates others. Many thanks for joining us today. Stay safe, stay well. Goodbye.